Okay, so we've just alluded a little bit to some of the technological advances that are coming. I work at UCLH, but I, at one time, was the chair of the National Outreach Forum, and until a few months ago, was the president of the International Society for Rapid Response Systems. And what's important about that is that I'm able to pinch ideas from people all over the country and all over the world, many of which will be included here. Now, my conflict of interest is I have no allegiance to any particular company, but I am one of the leads of a European-wide, European Union-sponsored project to develop the ultimate patient monitor. And just a couple of points to make about that. So this was a group of clinicians from across Europe who came together with patients to tell the companies what we want in a system. And the first thing we said was, well, we want the most important vital signs measured, although sometimes that's hard. And what are the most important vital signs? They are respiratory rate, blood pressure, and consciousness. And a whole bunch of the companies said, well, respiratory rate's quite hard and consciousness is really, really hard. How can we possibly do that? And they hadn't done enough thinking about that important sign, maybe the most important sign. And the second thing was that none of the devices that were out there were enabling patients or carers themselves to input into the system. Patients were merely passive wearers of one kind of device or other. So part of our spec is that patients can input. And how can they do that? Well, more often than not, the relay device between the sensor and the system is something that's a bit like a phone. And guess what? Some patients are capable of using a phone. Anyway, we've got 2 prototypes left after a competition that started with 160. This is one that's from Finland. And you can see this device here. Forget about all that other stuff. These are existing products that we're using to cross-check how well this one works. And here's another version of it. And we're going to be putting both the chest band and this device, or something a bit like it, on patients at UCLH and across the other European hospitals in the next few months. Okay, now, as a special treat, the day before Valentine's, I guess you're all thinking about that, take a look at the guy on the right, who could be your Valentine, I guess. So he's still out there, and a month ago, this is what he said. And actually, he said it before. He said that the NHS is responsible for 150 avoidable deaths every week, and he likened it to a plane falling out of the sky every week. Now, who in the audience thinks that that feels about right? Put your hand up if you think that we do kill 150 people that need not die every week. Put your hand up if you think that's true. So there's a few hands, but most of you don't buy that assertion. Okay, well, let's look at the data. So across the country, of patients that enter hospital and either die in hospital or shortly after their discharge, there are getting on for 300,000 deaths across the country each year. And what Jeremy Hunt is saying, that around 8,000 are avoidable, which is a bit more than 150 a week. And if you average it out by all the trusts, it will be 1 a week per trust on average. So where does that come from? Well, this is Helen Hogan's work, where they reviewed the cases of a whole bunch of trusts and averaged them out and said that typically 3% of deaths have a reasonably high chance of avoidability. Now, most of you didn't put your hands up, but what I would urge you to do is to go back to your own hospitals, and this sort of alludes back to what we were talking about earlier, about looking at the evidence properly, and then come back next year and say, we couldn't find a single death in our hospital that we think was avoidable. And I think you'd be stretched to do it. Or you're not looking at the right information. Okay. So this has been alluded to already. Now, we've talked a little bit about hospital-associated infections. And, of course, pressure ulcers are a problem and falls are a problem. These are all things that could lead to deaths. But by far the biggest cause of death in hospital, according to the chief medical officer, what does he know, is failure to act on or recognise deterioration. And that's what we're going to focus on. Okay, now there are many reasons that we could try and capture why a patient might deteriorate and why we don't always rescue them properly. And some of those issues are to do with the patients themselves, how we monitor them, how well we understand their background comorbidities, their frailty, the things that make them more likely to do badly. And there's a whole bunch of hospital-level factors that have been sort of touched on already. And my colleague Tim Bonici has tried to encapsulate that in this, and as you can see, it's complicated. If you look at any deterioration or any death, it's complicated. Now, I'm not as smart as him, so this is how Chris Suby and I have articulated these issues. The bottom line is you've got to be able to record your observations reliably, day and night. You've got to recognize the abnormalities. You've got to have a system for reporting. And by the way, that's hard. There's a very widespread literature that tells us that the nurses or the healthcare assistants on the floor find it quite difficult to call a doc or a senior nurse, and there are all kinds of cultural and hierarchical reasons why that's made difficult. And part of our job as leaders is to make it easier to make that call. Of course, there has to be a response, and we've done a lot better on the observation side, and we need to start thinking about the quality of the response, both the timeliness and the quality of what's done, and quite often this has to go into a repeat cycle. Anyway, that kind of schema can be turned into an approach to looking at your patients as and when they do badly. So you could choose a few cases. Those patients that have gone to ITU where it wasn't planned, or have had a death or a cardiac arrest, and you could see if the features that I've described were done well or not done well in the lead up to that event. And that's one way, a fairly quick and dirty way of seeing where the issues in your organization are. Now here's the thing. This was alluded to earlier. It's an elephant in the room. There's a huge body of evidence growing, and a lot of it British, but also European and from around the world, that absolutely talks to the issue of staffing. So you can see some of the points here. If you have too many temporary staff, there are likely to be problems. If you don't have enough RNs, there are likely to be problems. And we're not just talking about trivial problems, we're talking about problems that affect the recording of vital signs, we're talking about length of stay, and we're talking about mortality associations between poor staffing and patient outcomes. And there's a paper that's just come out from Gary Smith's group that will be in resuscitation this coming month that absolutely shows the linkage between RNs in particular, and when things are tight, their inability to monitor the highest acuity patients with high news scores, and how that seems to be linked to mortality. So, how are nursing establishments measured or calculated in your hospital? Well, in most hospitals, it's done by a couple of weeks a year, maybe 4 weeks a year. Somebody comes along and measures the average level of activity on that ward. And that's fed into an algorithm that says, well, on average, this is how many staff we need. The issue being, if you're a statistician, you would know that sampling 2 or 4 out of 52 weeks probably isn't going to capture the variability that would happen across the year. What happens to the ward when they suddenly get 2 or 3 admissions from the ED, or a couple of patients with mental health problems or dementia are running around the ward, running riot, or there is a step down from ICU, or there's a cardiac arrest? Are those kind of issues captured in a way that enables us to flex up and meet that set of needs? Well, the answer is not, if you go by an average. And we know for sure that one event on a ward, a critical illness event, increases the likelihood of another patient, or maybe another couple of patients, having an adverse event in the next few hours. The data is there. And why is that? Well, half the ward staff, those that there are, will go to the first one. Some other people are not getting monitored, they're not getting their meds, they're just not getting looked at. And there's also the strain on the staff themselves in terms of maybe being somewhat upset or distracted by the first event. The data is there. So we need to have the flexibility in the system to do that. And one of the issues is that although Robert Francis and a number of other national bodies have said that you need to have somebody who's supernumerary on a ward, who's got an overview of what's going on and can support staff, that very rarely happens. So am I saying that we should have more staff? Well, I sort of am, but that would be very expensive across an entire hospital. But at the very least, you could think about having a supernumerary person on at least the 3 or 4 wards which have the highest risk patients. Okay, so what are the 2 safest places in the hospital? Well, the first safest place are the offices of the board of directors. And the second safest place is the ICU. And why is that? They've got the sickest patients, the highest risk patients in the hospital. But in most reports, most reviews of safety in hospitals, the ICU generally does pretty well if you look at national reports of each hospital. And one of the many reasons is because they have mandated a nurse who will have oversight of the whole area and is supernumerary. So why can't we follow that elsewhere, at least in a few areas? But it isn't just about that. It's about, even if you don't think you can do that in the first instance, on a given day, what are the hot spots in your hospital? And now we have electronic systems. We ought to be able to work out, so here's a ward, you can see about 2/3 down, which has got on this particular day, got a high number of high acuity patients. So today they're above average, and that means they need some help. And it's there, visualized. Of course, acuity is not the only issue. There's also dependency. So if you've got 5 patients that need feeding, that'll be an issue. If you've got a bunch of patients who've got very high medication needs, that'll be an issue. But with an electronic patient record, you ought to be able to capture both acuity and dependency and have a real-time heat map and at least move some of your staff around, even if you haven't got new staff, to deal with that. That would be the smart thing to do, and it would be the safe thing to do. Matt's alluded to this. Having a common language of deterioration is critical, and there's pretty good evidence that it's been helpful. So this is some work that we did that looked at cardiac arrests across the country. You can see they've come down, and the main point is that the addition of news into systems accounted for much of that improvement, because it means we can all speak the same language. So don't mess around changing the scores for particular groups of patients. We use the same score for everybody, so we all understand how unstable their physiology is. You could choose to alter the response to particular levels for particular patients, but you do that in a professional, well-judged way. That's a different thing. Of course, news scores are not the be-all and end-all. And thinking about the patient's background characteristics, their frailty, ought to be part of your everyday thinking about each patient. And this is the back of the paper chart that we had until we got an electronic record. We asked patients on every round how they were feeling, in the hope that they would sometimes give us information that would be useful. And that goes back to the interfaces with the technology. The good devices that have got through to our final stages enable patients to say that they feel dizzy when they stand up, or they've got new pain. And that adds information that is useful and involves the patient. Matt talked about this. This is Dutch work, which shows that nurses or other clinicians' recognition of essential signs, some people call them soft signs, but let's call them essential signs, like the noise of the breathing, or the colour of the patient, or just, as the Dutch call it, the look in the eyes, is useful extra information. And remember, in the States, where they've got a problem with alarm fatigue from electronic health record systems, there's one study where over 80% of best practice alerts are ignored because there's just so many, some patients generating 100 BPAs a day. The ones that are not ignored, in other words, the ones that are validated by a nurse, seem to be much more predictive of deterioration. So in other words, sure, you have some escalation criteria built around an early warning score, but you add to it the opportunity for the nurse or other people at the bedside to validate it, say it's important, and then you'll have a more nuanced system. Patients themselves might sometimes be unable to make a referral. If you want to talk to her, she's in the room. Mandy O'Dell has pioneered this work in Berkshire, where they enable at least some of their patients to make a direct call to their outreach team if they're not getting satisfaction locally. They don't get a huge number of calls, but of the ones that they do get, they seem to add genuine value and add to an overall feeling of safety and patient involvement across the organisation. And this is sort of really based on the world of paediatrics, where they've been doing this kind of thing for a long time. A clear protocol is important. This is what we've got to with news, and it may turn out now with getting more data that we can make this more sophisticated and subtle. And we need to understand what happens when the patients that are what happens to the patients that are escalated. So these are two studies that we did. They're multinational, multi-centre, but actually most of the data comes from the UK. These are the outcomes of patients that are escalated with a high news score. Guess what? Many of them are old and frail. About a third go to ICU, if you've got an ICU bed. About a quarter get treatment limits. Now, these are mostly people that have already been in the hospital for a while, but it takes the visit of the outreach team to really think about things and get things organised. And 10% are dead in a day. 25 to 30% are dead in a month. So they're a high mortality group, high risk group. And one of the things we need to appreciate, of course, that lots of patients in our hospital are in the last year of their lives. So this is Scottish data. Every single hospital in Scotland studied a third of patients in the last year of their life. And if they're elderly, that's a higher figure still. So we need to start being smarter about diagnosing dying. The outreach team does a lot of that, but we should be doing it much earlier. So the pioneering work in this area, as quite often is the case, has been done by Ken Hillman, who's the father of rapid response systems outreach from Australia. But his experience has sort of taught him that we need to start thinking more about those people who will not benefit from aggressive treatments. And here's a fairly long list of criteria, but a lot of it is about vital signs and comorbidities that can be used to predict who's dying. And this has more recently been validated in several centres around the world. Now, of course, you've got to be careful about this stuff. How could it be portrayed if this kind of information is being used? This is what the Daily Mail said. It's the death test. Interestingly, they still publish that checklist on the right. Okay, so we need to think about these things. We've got electronic data that can help us with this sort of predictive work, but how we talk to our patients about it and their carers and their families is tricky. And some of us, or a lot of us even, feel quite uncomfortable about that. So I'm going to almost finish by sort of plugging my colleague Gillian Hartin from UCLH, who's been leading our outreach team for many years and has come to understand that much of the work is to do with this acute care, end-of-life care interface, and has developed a program that is just being rolled out across our HSN about how to have these conversations. And it isn't just that usual role-playing thing, it's getting people, the clinicians themselves, to think about their own ethical codes, the law, professional standards, what different cultures might think about these things, and so on and so on. And then you also get to practice. And if you're interested, then make contact with her. Okay, so these aren't national standards. These are just what we've learned in our organisations over the years might be useful for you to take away. So first and foremost, those of you that didn't put your hand up when you thought there might be avoidable deaths in your hospital, you're not paying attention. All hospitals need to look at the care of patients at risk. And why it's not top of your list of priorities, even above falls and pressure ulcers, I don't know. How can you explain that? Secondly, it's probably helpful to have a dedicated substantive team There are some hospitals that manage to organise their response around an ad hoc team, almost like an old-fashioned cardiac arrest team, but those people will come and go over time. Having a dedicated team that has organisational memory, that knows that Ward 10, when Sister Jane is on, can look after pretty well anything, but Ward 5, when Charge Nurse John is on, might be a bit ropey, is really, really important. Those kind of human factors are really, really important, and a dedicated team will do that. That's ours at UCLH, or some of ours at UCLH. And the evidence is there too. So here are 3 meta-analyses of data from around the world telling you that these sorts of systems reduce mortality. Okay, you've got to listen to people on the ground. Going back to that very complex matrix, if you're not talking to the staff on the ward, from the cleaner to the consultant, about what was going on when bad things happened, you just won't understand, you won't be able to fix it. Of course, top-down help is useful too. Now, outreach teams are often a remarkable example of how much stuff has come from bottom up, but ultimately you will need senior leadership on board. And we need to recognise that we can't save everybody, and that not everybody wants to be saved, in fact. A common language of deterioration is important, and news is probably the best one we have at the moment. Getting the right thing done is hard. You have to understand behaviour. Increasingly at UCLH, we're using the behavioural change model of thinking about capability and opportunity and individual and team motivation to do the right thing. If you've got an outreach team, they can be your canary in the mine. They're seeing all the bad stuff that happens around the organisation. Oh, just as an aside, remember that as well as physical stress and de-stress, there's plenty of psychological distress out there, and I think we're only just starting to understand how hard it is to be acutely or critically unwell and what that does to the mind and body. And that will be easier to recognise if we give patients a voice. And very lastly, our international society has put together these evidence-based metrics that I might just pause a moment for you to look at and maybe think about. Now, some of them are pretty obvious. Tracking cardiac arrests is a reasonable way of looking at of one bit of the iceberg. Making sure that patients have their vital signs done on time and are responded to in time, that's all useful. What do you do to help patients themselves voice their concerns and maybe activate the team? And down the bottom, you can talk about the safety culture in the organisation. And economically, how do we justify the costs of this kind of stuff? Well, one way might be to look at the ICU costs of patients that are unplanned admissions there. And I shall finish there.